So today we're going to talk about mental health. And in one time in your career, you're going to have to deal with mental health issues. The primary care providers are depended on a lot to treat mental health because of the limited resources for mental health services. There's a lack of psychiatry, and the advent of the psychiatric nurse practitioner does help alleviate this burden. Some of the chief complaints related to mental health disorders, and these are things that are going to trigger you. Now, this is all in a subjective area. Sleep disturbances, and that can be too much sleep or too little sleep. People who are depressed most often have this. Bipolar people also have this. People with anxiety because they can't shut off their brain. Mood and emotional alterations, they can be very moody, angry, sometimes very subdued. Weight loss or weight gain. People who are depressed again sometimes don't want to eat, or they go to the other extreme where they are eating too much. Cognitive difficulties, difficulty concentrating, doing tasks, ordinary, simple things that they do every day, having difficulty with completing their work on time. Personality changes, and this is most likely due a lot of times to patients elderly who have dementia, Alzheimer's disease. They'll go through personality changes, and that's one of the triggers or questions that the neurologist will ask families. Has the person gone through any personality changes? Then they know how to gauge the staging of the disease. And then lastly, delusions or hallucinations. These are people who lose their contact with reality. The schizophrenics talking to themselves, hearing voices, talking to other people that aren't really there. They become delusional, and they really believe in those delusions or those hallucinations. Assessments for mental health status. When you're dealing with assessing mental health status, and there's a lot of tools you can use. Mini mental status exam, the mini-cog, and the mini-cog is the thing that I use the most, and I use that the most because it's the quickest and it's reliable. You have to ask the patient if they can remember 3 items and then have them do a clock drawing. The other things you want to look for in mental status is their appearance. How do they look? That's just like the general appearance. Are they disheveled? Have they bathed? Do they care about their personal appearance, their hygiene, that kind of thing? Behavior. How do they act? Are they acting appropriate for the office setting, or are they just totally not at all? Do they say things that normal people would not say in the setting that you're in? Their cognitive ability. Do they understand what you're asking them? Can they follow the logical flow of the conversation you're having? Their emotional responses. What do they burst out in crying for no reason at all? Are they withdrawn, just not talking? Do they make eye contact? That kind of thing. Speech and language. Is their speech clear? Can you clearly understand them? Are they talking really at a rapid pace where you really can't understand them? They keep going on and on and on and on. That is significant. When we're going to assess depression, if you use the acronym SIGI-CAPS, and again, this is bolded as you can see, so this will probably pop up again for you next week. This is a real good way to include in your subjective data for assessing somebody who you feel is depressed. So you ask them, and we said this before, about their sleep pattern. Are they sleeping too much? Are they sleeping not enough? Interest. Do they have interest in doing the things that they normally do? Are they not doing the things that brings them pleasure in the past? And that could be things like, going out with friends. They play golf every week and now they're not at all. Do they go to church but now they're not? Simple things like that. The next is guilt. Do they carry around any guilt about anything? Do they feel like they're being blamed, or do they blame themselves? Energy. Do they have loss of energy where they're just blah? Or do they have too much energy where they have to be doing something all the time and going 100 miles an hour? Concentration. Can they concentrate in completing a task and then moving on? People who have ADHD also often have this problem. Are they able to do two things? Are they able to follow your conversation? It's concentration also. Appetite. Are they eating too much? Or are they eating too little? Has their appetite changed at all? Psychomotor activity. And then lastly, and probably the most important thing, is you have to do a lethality assessment to see if they're suicidal, homicidal, or a danger to themselves. You always have to include a lethality assessment when you're assessing somebody with depression. So all the time, don't forget the lethality assessment. Risk factors for suicide. And you can ask the patients these questions, and sometimes it's difficult, but once you get used to them, just like a sexual assessment or any other alcoholism, anything like that, just by doing this will become a lot easier for you if you do it several times. So when you're assessing somebody's risk for suicide, you want to see if they've done this in the past. Have they had any attempts? Have they had depression in the past? Do they have a family history of suicide or severe depression? That's very key, because we know that genetically that depression and suicide ideation can be carried through. Do they have problems with alcohol or other CNS depressants? It can be a mode for them for suicide. Do they feel hopeless or helpless? Like anything they do, they just, I don't really care, I can't do anything about it, and that type of mentality. Are they attracted to death? Are they going on the internet and researching this? Are they formulating any type of plan? Do they talk about death a lot? Those could be clues for you. Losses or separation. Have they broken up with people? Have they had a divorce? Have they had a separation? Have they had, something with a significant other or parent, or even a sibling or a friend? Those kind of things. Do they have any serious medical problems? People who have terminal illnesses are at risk for this. And there you see it, perceived or real. If people, are not thinking clearly because they're depressed, they can perceive things that are not really there. Take their age into consideration. Teenagers, and then the opposite end of the spectrum, the geriatric patients, are at higher levels of risk for suicide. And then the last one, which has become, I think, main place obvious, people giving away things, constantly. That's a clue for you to assess for suicide or, lethality. Again, bolded, common signs of generalized anxiety. Are they excessively anxious, or do they worry a lot about a number of things most of the day for the past 6 months? Usually they'll have one thing or a couple things that they dwell on, and that's all they can focus on. If they've had this for 6 months or longer, that would be one of the criteria for anxiety. Do they have difficulty controlling worry? Are they a worrywart? Do they worry about everything? And then here's the other criteria. Anxiety or worry associated with 3 or more of the following on most days. So on an average week, if they're doing this, 4 or 5 times in that average week, then yes, they have anxiety and going on for more than 6 months. Are they restless, feeling tense, or all jacked up, all keyed up? Are they complain of being easily fatigued or sleep disturbances again? Too much, too little? Do they have difficulty concentrating? Or is their mind like going blank? They'll be trying to explain something or talk to you, and then they'll say, I've lost it. I don't know what I was going to say. Are they irritable? And if you know that person, they're not usually grumpy, and then all of a sudden they're grumpy about everything. They become irritable. Or muscle tension. Are they tense all the time? That's another key. Dig fast. And this is an acronym for diagnosing bipolar disorder. And again, this bolded D is for distractibility. Are they easily distracted from what they're doing? Indiscretion. Do they have none? Grandiosity. Do they have these big, grandiose plans or ideas? F is for flight of ideas. Do they have these flighty ideas? They just get these ideas and then they act upon them. A is for activity increase. They're always moving all the time. S is for sleep deficit. These people can't get enough sleep sometimes. And talkativeness. These people just talk and talk and talk and talk. I had one patient actually today, the day I'm doing this podcast for you. He had bipolar, stopped his medicine because he said that, they're man-made and he wants to do everything naturally. And all he did was for 35 minutes was talk non-stop. So that's one of the keys. And this gentleman is definitely bipolar. And you could see all of these dig fast acronyms when I'm sitting and listening to the patient. Safe. When you're assessing somebody for domestic abuse. And these are good for the clinical nurse specialists who are going to be in acute care settings to assess for this. Safe. The S is for, do they have any stress in their relationships? Is it safe for them to be with their partner? And again, these are all go in your subjective data. A, what happens when their partner gets angry? Are they violent? Are you afraid most times of your partner? And then simply ask them, A, have you been abused? The F, do they have financial resources for themselves? Is there any firearms in the home? And what do friends and family know about your situation? Sometimes they don't. These people are very private because sometimes they are ashamed. And E, emergency. Is there an emergent situation now? What kind of plan do you have if an emergent situation comes up? Common mental health disorders. These are things that we'll commonly see. Depression. As a primary care provider, you'll see a lot of that. Mania. People who are bipolar will go through mania. They'll be really high and then they'll be really low. You have to look for their cycling, they call it. Schizophrenia. It's another thing that you'll see as a primary care provider, but that diagnosis is usually more suited for our psychiatric nurse practitioners. I mean, you can follow them, but management-wise, you probably want to get some help with psychiatric NP. Anxiety, very common. General anxiety is seen in the primary care office. Delirium and dementia. You want to know that to know the difference between the two. Dementia is chronic, happens over time. Delirium is acute. So delirium is acute, dementia is chronic. And then considerations for pregnant patients related to mental health. You need to be sensitive to the pregnant patient regarding the signs and symptoms of depression and anxiety, especially in the postpartum stage. They can get the baby blues very quickly, and it can be very nasty. So you have to watch for that. Also for postpartum psychosis, which is more serious than postpartum depression or the baby blues.